Welcome to November 17th, this edition for Transformation Tuesday. Today we have an unbelievable panel discussing the changing medical landscape of robotics. And we're going to hear from industry, we're going to hear from providers, we're going to hear from innovators, all converging on the space of robotics and what does it mean not only in the OR, but preoperatively, postoperatively, and thinking about the platform of data. We have a fantastic panelist, and so without further ado, why don't I quickly introduce all of them, and then we'll have each of them kind of kick off a little bit about who they are, what their company represents, and in fact, frankly, what they want to get out of this hour. So with us, we have Robert Cohen. He's president of digital robotics and enabling technology at Stryker. Thank you very much, Robert, for joining us. We have Bob DeSantis, who is executive vice president at Intuitive Robotics. We have Dr. Kaouk. He's the director of the Center for Laparoscopic and Robotic Surgery at Cleveland Clinic. Mike Pereira, president and chief operating officer at Ximedica. Doug Taney, chief operating officer at Corinthis Robotics. And lastly is Leanne Teplinski, vice president and general manager of worldwide robotics, Zimmer Biomet. 6 different perspectives, 4 different companies. But let's start off, maybe with Robert, if you wouldn't mind. You're right in front. Give a little perspective. You have kind of digital and robotics, and talk a little bit about it's not just the robots, but the actual digital space and what has been kind of your enabling strategy with Stryker.
Yeah, so thanks for having me. Actually, the entity that we're in the middle of creating, digital robotics and enabling tech, is really the result of our first entree into robotics at Stryker, which is now the Mako surgical robot, hundreds of thousands of procedures completed. So with the applications, we've seen not only more information on a patient that's actually benefited surgeons, but we've actually looked at now the pre-op information we can get on patients is a level of information that we never could get before, whether with hospital reported outcomes, whether pre-planning, intraoperative assessment of a patient, and then the final plan of that specific patient, and then attach that to patient outcome data, whether patient input, physical therapy data, look at return to work, readmission, reoperation rate. We're now in a continuum of care that we never had access to as an orthopedic industry from the data. So combine that with a robot that's an enabler, combine that with what we could do on preoperative plans, combine that with on the data postoperatively, we can now put that together and work with data in ways that could benefit automated planning, predictive analytics, as well as have an economic advantage. Like, for instance, should that person be in a hospital outpatient or inpatient? Should that person go to physical therapy? How do you manage that patient's expectations on return to work? It's a new world.
Well, it's an exciting new world. And Bob, I wonder if you could comment, a different perspective from Intuitive, or is there a common thread?
I think you're going to hear quite a few common threads, but maybe different approaches. So Intuitive obviously has been enabling a different approach to surgery now for 25 years, so over 7 million procedures. And the key word there is enabling. Right now it's been a lot of hardware and software and mechatronics that have kind of brought the MIS to more patients. But going forward, it's about providing more information. And I think, as Mr. Cohen said, it's more information during the procedure itself, but also previous to the procedure, integration of information previous to the procedure, during the procedure, and then post-procedure follow-up with outcomes, all really important to make sure that what we intend to do, we are doing, which is addressing the quadruple aim, improving the patient outcomes with our technologies.
That's fantastic. And I like the word enabling. So I'm not a surgeon, so ironically talking about robotic surgery, but we do have a world-renowned robotic surgery, Dr. Kaouk. So, common folklore is the robot going to replace you as the surgeon? Is it a replacement or, as Bob said, an enabler?
Thank you, Dr. Morris, for including me. This is really exciting. Definitely the world have changed a lot, and I'm talking to you today from Abu Dhabi. So from a different continent, behind me, that blue building there is the Cleveland Clinic, Abu Dhabi. So, that speaks volume, where we are today. Yeah, the robot 20 years ago was an extender to the hands and eyes of the surgeon. And now it's not enough to have an extender in the operating room. Enabler, yes, maybe facilitator, maybe beyond that, a smart assistant. So this description of the robot will keep evolving, and I'll take enabler for now. The robot, I don't think, will replace the human, because the human creativity is always needed, and it's very difficult to replace. We may be able to technically, improve steps, make ourselves more efficient in the operating room, and so on. But the creativity that the human mind brings is unique.
No, I like that creativity, and maybe Mike, from Ximedica, you make subsystems, and so I imagine you are at the core relying on the creativity of doctors like Dr. Kaouk to help kind of envision and shape that. Is that your kind of perspective, or would you rather have with the engineers who kind of just tell you how it should be?
No, that definitely from the user perspective, the clinician perspective, Dr. Kaouk's perspective, and others that are leaders in the industry, it's absolutely key that we enable them to succeed, right? And how do we make them how do we help them succeed is always the question. The technologies are evolving, that enable them to see better within a surgical procedure, whether they can automate certain portions of the procedure to assist them, really figure out where the value is to help the clinicians succeed. That's really the key aspect of how Ximedica helps clinicians as well as our clients in order to move forward. And the value and the clinician-centered approach that leads to patient outcomes, really all of those things have to be considered in every decision that we make. Engineers just are the vehicle by which we can make them, some of those, but certainly not the decision makers, right?
That's great. Doug, so commenting from Corinthis, Corinthis was recently acquired. Tell us a little bit about your journey and a lot of these common themes echoing true.
Yeah, I feel like we're at the bottom of the hill compared to Intuitive's millions of cases. We're about 5,000 vascular cases completed around the world for the Corinthis CorePath robotic system. But this company started with a premise of radiation protection, thinking about I think our evolution echoes what everyone said, that we are moving more and more toward enablement technologies that draw on the right side of the physician brain. We push left side brain tasks to the robot, things that can be repeated and distilled into a specific task. But I think the biggest focus for Corinthis has been taking everything we're working on and thinking about and beginning with a clinical outcome in mind. And for robotics to truly scale, I think as many of the people have learned from companies on this call, you have to get to something that's of value to both the physician and the patient, and then you've got the right formula. For us, in this passionate pursuit for remote treatment of acute ischemic stroke, where we can make a real dent in outcomes for patient populations.
Yeah, and with that kind of focus on outcomes, before our panel, we had a chance to chat, and Leanne, from Zimmer and Biomed, you talked a lot about the platform, the data platform, and as Doug just talked about, outcomes is the game. Tell us a little bit about, maybe our audience is just thinking it's the robot in the OR suite, but what are the invisible pieces that we're not thinking about and we should be thinking about?
Yeah, thanks for the opportunity. So, we need to be patient-centric and patient-focused. And so those are the kind of tools that we're trying to make sure that we bring to market. I think that there is truly so much to be learned and so many insights to be uncovered by studying and ultimately quantifying a patient's full continuum of care and bringing those objective measures. And we want to bring tools to market that are intuitive and easy to use. And so we're trying to bring some of those consumer expectations that we all have kind of in our day-to-day lives and our patients are used to into medicine and healthcare. And so whether that's how we implement those robotic workflows, or whether that's the kind of, bringing an app like My Mobility that is truly patient-centric and easy to use, and in a partnership with Apple, arguably one of the best consumer technology companies out there. We want to make it so that it's enjoyable. And I think that will actually make it, easier to use for everyone in the continuum of care. And if it's more enjoyable and more engaging for everyone, whether that is the app like My Mobility or the dashboards that we provide to surgeons or the surgeon-centric way that we put the robotics together, I definitely think we're going to win. And we've seen this actually in some preliminary results from our My Mobility clinical study. 80% of patients actually rated their My Mobility experiences better or much better than previous surgical or medical experiences. And so that's kind of the focus that we're trying to have for both the patient, and then bringing those same kinds of sort of fun, enjoyable experiences to the surgeon as well.
I like that perspective. So thank you all. That was kind of a two-part question and answer and meet and greet. But I'll start off with throwing the volley out. Lots of different companies out there, lots of different devices. Obviously, different orifices, different approaches. Dr. Kaouk, when you are as the center for robotics and laparoscopic surgery, you're approached by so many vendors. Do you see one magical robot fitting all needs, or do you see more of a hybrid approach, a symphony, if you will? And how does that kind of play out?
Well, robots are blossoming nowadays. So we used to have a very short list of medical robots, surgical robots available, being intracavitary. That means the ones that you can do surgery inside a patient, or navigational, like the ones used in orthopedics or neurosurgery. And I think we're at the stage where we're going to see numerous other new robots coming out. And we're going to get to a point to have a plan how to choose. I think it's going to come to a point where what brings value to a specific situation. So there will be no size fits all, I think. So you need to customize what brings value in this particular patient with patient characteristics, tumor characteristics, surgeon's ability. So if you combine all these factors, you will start picking and choosing. Sure, we may see combination of robots that do different tasks in the same operating room, and then the compatibility issue becomes something to navigate.
So maybe Mike from Ximedica, or certainly others, talk about compatibility, standardization. Obviously, each company in their own right wants to be the master of their own domain and kind of own that data and own that piece. And obviously for regulatory, for safety, for security, that goes without saying. But from your perspective, as you build the systems of systems, how have you seen interoperability or the ability to kind of play with others and data sharing emerge? And where do you see that going?
Well, I think a lot of it has been in discussions, and the discussions have begun, especially even on the startup side of companies. They absolutely want to provide additional value to the central platform surgical robot that would be in play, and even have secondary or tertiary robotic systems that can actually play in the same surgical suite and provide really strong value, as Dr. Kaouk was mentioning. And so those conversations have started with various organizations and how they can provide value and add value to each other. And we can definitely see that there's openness by some, and otherness, a little hesitation. But I think the market will absolutely push and pull people in that direction, especially when they start seeing the true value that other organizations can provide, and especially when they work together with each other, and not just to try to solve it all in one place.
Hey, Will,
please.
It's Doug at Corinthis. I think just some food for thought on this. I think we've learned there are places that you can generalize and places to specialize. So I think if you're talking about the data, some of the algorithms like machine vision. All of us can figure out how to find an edge and do something about the edge of whatever you're working on. But even in vascular robotics, we can't take a cardiovascular robot and successfully do a stroke case. We have to specialize, at least on the electromechanical component. I think procedure-specific robots with general purpose data stores are probably how we would see it evolving.
There's also
yeah, Robert.
Yeah, that's a great point. And I think also we sort of bundled up robots into the same conversation here. A soft tissue robot and what the objective of a soft tissue robot to get to a target and how you get to a target is very different than a hard tissue robotic, say for orthopedic total joint reconstruction. In that case, it's a more prescriptive robot where the software is geared towards where you place an implant, and it's the preparation of an implant and how do you get that implant specifically where that individual patient needs it. So I think it's spot on that you focus on the application, then you figure out what the best technology is for that application, then in turn do it. I could tell you, at Stryker, we write the software, we design the robots, and we actually build the robots specifically so we can have a robot arm hold a power instrument at the end of the robot arm. So that's a very specific robot that's meant for hard tissue robotic applications. Now, in turn, then you look at the continuum of care of, say, a total knee patient, and you look at all the elements of data collection through that continuum of care, and the robot becomes part of that ecosystem. So very specific to the application, very specific to the technology.
Yeah, and I think just you guys intuitively answered one of the questions from the Q&A. A couple of our bariatric surgeons posed the question, while they have a generalized robot, does the panel expect to see procedural-based robots? And it sounds to me the answer is yes, of course, and it will be on when appropriate, you differentiate in narrow and deep within a field, if that's fair to assume.
Yeah, if I could chime in. So if you look at the Da Vinci platform, it's been very purposely designed for really pelvis up through the thoracic. But general applications in that particular area, which are not procedure-based, but they are certainly cavity-based and provide applications in quite a few procedures. And we're seeing quite a few entrants try and develop platforms, develop systems that are differentiated. And there aren't very many to date that we haven't tried. But one of our guiding principles was enabling in the broadest case of procedures that we can service. So I think, as was mentioned, with the hardware end of it, but also the software end of it and the data side of it, which is what is the scope of your treatment? And so, do you want a soft tissue robot communicating with a cath lab, or a cardiovascular robot, or a orthopedic robot? The answer might be yes in certain instances, but the answer might not be no also. So I think it comes down to what is the need of both the OR staff, the perioperative staff, and the institution, and how can you best provide that information in a very usable format.
I do think that there may be some unique and great opportunities that we have seen internally, that the robot that we have today for ROSA, for orthopedics, for example, well, now, yes, it's certainly focused, and the applications are focused on sort of large joints. We were able to leverage software and hardware capabilities from our brain platform. And so the level of accuracy that you can get with respect to, all the learnings that we had there can then be applied into orthopedics as well, even though some of the applications may be different. So I think we may see some interesting things over time that, maybe pull in some of the knowledge and the smarts, I'll say, from some of the other different applications across medicine that may be valuable in different spaces that maybe we wouldn't have anticipated.
Yeah, no, I love that exploitation of things that you don't anticipate. And I would love to kind of hear the perspective. So Dr. Kaouk, you oftentimes you remark about thinking about ways not to automate what you do, but to automate things that you physically could never do. And there's two aspects of that. One is, your current mechanical limitations that a robot can do. but there's also a time and space aspect where you physically, you could be in Abu Dhabi. I wonder if you could comment to the audience those aspects. So, to my eyes, is irrespective if you're a narrow purpose robot or a generalized robot, the opportunity would be to exploit things that otherwise the human can't do, and two, to exploit that kind of that time space differential.
Right. Well, thank you. Absolutely. The robot being in the mechanical age, I think is over, where it's just an extension. And to get to the next stage, we will be able to see beyond what our eyes can show us at the surface of the organ, if you will be able to tie the robot to preoperative imaging, for example, and you will be able to do moves with your, robot that's not limited to your wrist, because the robot mimicking what the human being can do is a limitation to the robot. If I'm going to move a robot only with my joysticks, my wrist can only turn as much, but the robot can turn 360 degrees. So do we want a robot that can be perfect in mimicking a super surgeon, or we want a machine that can go to its full ability without ties to the limitations of a human being? So sure, this is a far-reaching goal, but we can start moving into small steps with that. Do you want to have a joystick that just can do that, or you will be able to just draw the trajectory and automate that so that the needle can turn 360, for example, instead of dig it from one side, go to the other side, pull it from the tip and out.
I'd love to hear from, yeah, please.
I was going to say, I like what Dr. Kaouk's saying. That's where we started on the, oh my gosh, we've got to do something physicians can't do. Let's do remote. You can't be in two places at once. So that kind of drove us there. But I think the more valuable approach we had, and I think what I heard Jihad talking about was, we've tried to take a look at what clinicians are doing in practice, understand what outcomes they're looking for, and what parts of the task are most important for that outcome that they don't think work well today. And I think Jihad's wrist analogy is a good idea. And if we're able to, and at least in the vascular space, focus in on those things that are most important, the physicians are least satisfied, that drive an important outcome, that's as valuable as doing something the physician can't do. It's doing it in a way that they would envision it being done better.
Yeah,
I would echo that in a big kind of way. And in fact, with soft tissue robots, it's one, take the perspective of hard tissue robots. So the first objective of hard tissue robots is getting closer to that individualized medicine that we cannot provide instrumentation manually in surgery. And it's about hitting a target. So let's take a total knee. You could three-dimensionally understand where you want the joint line, but humanly, looking at all those data points, it was virtually impossible to assess where the plane is for that joint line. So now we could put with robotics a more precise and more accurate and implant in the right location. In the future, now let's go back to that wrist comment. We should be able to go through smaller incisions, not require line of sight, be able to machine different bony geometries, not restricted by the manual instrumentation of, honestly, that we've been stuck with for decades. That's limited innovation.
And I think there's even more to be. I think there's even more around that with respect to the data analytics that we talked about earlier. So the better we can understand exactly kind of this continuum of care as we go back into the OR, not only the movement, but the exact placement of the implant, or what should we be doing pre, intra, and post-operatively for the best outcomes for these patients. So I think pulling all the pieces together with the data analytics that we can get over time here as we quantify patients through apps that otherwise I think will be really valuable.
Yeah, I was going to go back to, I think a really good point was made, which, if we think back to the advent of minimally invasive surgery, I don't think anybody questions that if you can do something as well minimally invasive, it's better for the patient than open surgery. But in order to get there through soft tissue laparoscopy, quite a few compromises have been asked of the surgeon. So in many cases, we've taken away their ability to have wrists. We've asked them to no longer have three-dimensional view, but to look up at a two-dimensional view, to give up their sense of touch. So in a lot of ways, we look at the first step as kind of restoring those senses, and to, through a wrist, through three-dimensional sight in an immersive environment. And to Dr. Kaouk's point, our objectives at Intuitive are then to kind of expand that to superhuman capabilities. So things that actually go beyond human capabilities, whether that be imaging and vision, or whether that be haptics or touch or information, or really the amalgam of all these senses to a new level.
Yeah, I would absolutely agree with that, Bob. I think the taking the preoperative, what we thought was preoperative visualization, now make it operative visualization, and multi-frequency, visual kind of, and from different angles, so that you make not just a superhuman, but a super physician, right? Beyond what a physician normally could do. But it's going to take evolution, and you all have been collecting data, lots of data, like Leanne has been saying, in order to see, okay, what is the right position to be that correlates with the outcomes? What is the correct, best outcome based off what the top surgeons have been doing in a particular area? And by taking that, you now, instead of taking and limiting physicians and surgeons to just the normal controllers that they're used to, you're actually taking them beyond the controller and actually instructing the robot or the surgical, whatever the automated surgical procedure is going to be, to actually do, so that you maintain creativity, but not at least the what hinders surgeons from actually doing whatever they need to do, right?
So what have been I don't want to say the barriers? Is it the natural evolution? So this mental quest, which I get, is these superhuman traits, these ability to determine the best path of a line that otherwise the human wouldn't be able to characterize. How far are we there? Is it a limitation of the computation? Is it a limitation of the FDA and regulatory oversight? Is it a limitation of actually the physicians being recalcitrant to give over controls? I'm just curious, as a non-surgeon, what are those barriers that you see is kind of at the cutting edge, no pun intended, of the space? What are the pragmatic limitations, and what is the realistic time horizon where semi-autonomous surgery, or at least best path automation, might be come to fruition?
So if you take that question and you actually look at the adoption curve, you always have your early adopters, your mid adopters, and you look at levels of evidence that those different groups expect along that journey. I'll give you a real life example. Let's take the total knee application on the Mako Stryker robot. So that was really launched 4 years ago in a big kind of way. Now that's new. That's totally different. Introducing a robot in surgical procedure with auto planning and all that, or not auto planning, but planning preoperatively dumped in the robot. Then if you take a look at the adoption. So right now, Stryker, major orthopedic company in the United States, 40% of all Stryker total knees implanted in the United States go in robotically. That is a massive transformational change, which means there's an adoption of a technology, and I don't care how good company is. That's about surgeons telling other surgeons they're seeing improved clinical results, and they now have enough peer review literature that the next round, so I say peer review literature and showing a true clinical benefit was needed by many, and now, depending on whose robot, what implants and things like that, we're getting to that point now. So that 40%, I can actually see when the majority of Stryker knees implanted in the United States will go in robotically, and that's fascinating.
Yeah. Others?
To answer your question, Dr. Morris, I think it's a little bit of all of the above. And I think the key word would be value, defining value. And sometimes with new technology, the value will not be apparent, at least, to the most. And it takes time. So you had this hard tissue navigating robots, and they're out in the market. Early adopters will use them. They will come with early results that show great outcomes. Then you have more people out. Then the value becomes obvious. And suddenly, it becomes a platform that no-brainer. Many people are adopting it, encouraging companies to invest more and then upgrade it to 2.0 and the 3.0 version of that. And then it comes back to the crowdsourcing in the hand of the surgeons, and the cycle continue. And that's how we see a lot of these robotic platforms improving.
Yeah, Dr. Morris is going to say it's a little bit about what you said, evolution versus, but I think sometimes life changes, just like the best laid plans in life. You can have these brilliant static preoperative images, and then when you run a 4 French catheter up an artery, it completely changes its stiffness, its responsiveness. And so some of it's just hard work that needs to take time to be safe for patients, to make sure that you're accounting for those dynamic things that can happen in real life versus well-laid plans that are done preoperatively. And when you put patient safety and case effectiveness kind of to the top of the list, solving for those challenges of dynamics in a case are important and take time.
I appreciate, I think the concept of it's iterative, right? This is an iterative game and one of collaboration. What I appreciate is you all as, day job competitors all taking the time to kind of share, dispel myths, but also kind of share the passion, enthusiasm that each of you share in the space. I think that is a collaboration that is definitely warranted and needed in healthcare. And then the second is how industry and partners collaborate with provider systems and physicians and nurses, et cetera, to create that, and patients, right? Ultimately, it is the patient and ascribing the value. I interrupted, Leanne, you were commenting.
Yeah, I just want to make the comment around, again, just going back to the patient, I think we're at a tipping point for a couple of reasons. Some have already been mentioned, but again, as patients are used to having technology in their day-to-day lives, I think more and more we're seeing that they're expecting it in their medical procedures as well, and everything that's going on in healthcare. So I think, that's going to be something that, surgeons and industry are going to have to deal with and leverage and be able to bring this technology then to them to be able to improve their care and their outcomes. And alongside that, efficiency and cost should really come along with that if you're getting patient outcomes. And then I think the second component of that is that we're at a tipping point where we need technology. I think that we've gotten really good in a lot of avenues with outcomes and with, length of stay and with the cost. We've sort of hit these plateaus in a lot of areas. And so if we can introduce meaningful, impactful technology throughout that patient's continuum of care, I think that's where we're finally going to get, some significantly improved measures. But having, again, the focus on the patient and then the focus on that, continuum of care and the places in the continuum where we can be the most impactful with technology, I think is going to be really valuable and see that adoption curve ramp quickly.
I want to emphasize also, I totally agree with Leanne and Will, what you said. Also, collaboration is a key thing. So with every iteration, we get improvement. And as we've seen over the last 20 years, each iteration, the time between each iteration is halved. So, Robert mentions, in 4 years, 40% of their robotic systems are doing the procedures. Well, if it was intuitive 20 years ago, that wasn't that fast, even though they have one of the best products out there, they paved the way for everybody else. So the iterations are going to speed up between, it's going to be every 4 years, down to every 2 years, down to every year coming out, because the platforms are set up a way to accept new technologies in them so that they can increase their capabilities and their value to the surgeons faster and faster. And the question is how do we make those platforms open enough to accept not only the innovation that's happening within a company or maybe a couple of companies that are partnering together, but with maybe more companies that could provide value and really accelerate the process and the value provided to surgeons and eventually to patients.
So the only challenge there, though, that we have to remember is we are in a regulated space. And when you look at the regulatory space and you look at changing of software and you look at open software, it's one thing if a software and you want to validate that the surgeon is guiding the end to a soft tissue. I could tell you right now, and we've looked at partnering. So on the hard tissue side, because the purpose of the robot on the hard tissue is put an implant in, and the FDA controls the implant, which remains in the patient, very prescriptive. The combination of things is somewhat of a challenge. Now, that's on the technology intraoperatively. And a Stryker now, I'm looking at combining different equipment, but that's for another webinar. But now take the data element to it, right? There's no reason we can't partner with third-party payers. In fact, within Europe, there's no reason we can't partner with some countries and governments in socialized medicine areas or in other places that are emerging countries. And now if we partner on more patient information on the front end, and then we get into predictive analytics, or we can get into auto planning, or we can manage patients' expectations and actually look at the whole economics as well on top of things, then I think that's where I think the first round partnering will see an early benefit, because the data coming out of the robot, the data coming out of the pre-planning, then add demographics. We'll be able to say, let's say you're a 64-year-old patient, rheumatoid arthritis, BMI of 39. What's the best implant for you? Are you outpatient or inpatient? How long physical therapy? How long should you be on pain medication? When should you return to work? When should you return to flexion? That's the exciting part of partnering now.
And a lot, I mean, our chat is blowing up, which is a great sign that people are engaged. So please keep on asking questions. I'll do my best to get them. We talked a lot about data and the data exhaust, right? Preoperative, postoperatively. Let's talk about intraoperatively. We have one of our surgeons asking the question, are we capturing the actual video feed? We may not know what to do with it yet, but perhaps it's the unknown unknown. Are we capturing that, trapping it, and perhaps using AI and ML to understand performance characteristics, outcomes, or maybe even predict risk in surgical outcomes? Curious on your thoughts on the data exhaust.
Yes.
Yeah, so I was at Intuitive. There's mega data on the millions of procedures. Capturing it just by in and of itself is no simple challenge. Once you capture it, then interpreting it, leveraging it, and then being able to actually say something definitive back to the surgeon, all are wrought with significant challenges. Some of them technical, some of those compliance and regulatory wise. That said, where there's a will, there's a way, and I think there's great value there. And we are steeped and deep and immersed in leveraging the data that we can pull off of our systems, not only visual data, imaging data, but kinematics, usage, et cetera, tying that back to outcomes. And that's one of our key investment areas.
Yeah, we certainly don't have the level of data that Bob has from the intraoperative robot, but we're introducing sort of a smart OR. And so where you will have cameras, we can understand, when you start and stop anesthesia, when you're using what components of the robot, there's when someone leaves the room and comes back in, so that we can understand potentially infection rates, things like that, how many times it opened, how many packages are opened. So we can start getting a much more rich picture of the actually, what happens during the procedure itself. So we'll have the ROSA data, the smart OR data, which can then all link in together, pre and post-operative with my mobility and a smart implant, that now goes out to 20 years, not just kind of the 90 days post-operatively. So being able to do that, have all of that enriched data intraoperatively, linking in ultimately to pre and post-operative plans, electronic health record. I think it's going to be hugely valuable.
Yeah, Dr. Morse, we're doing, I agree with there's some heavy lifting here and it's fraught with challenges, but
come on, all you have to throw out buzzwords like AI and ML and it's
no, but it's for us, it's really interesting. We're all on the bench with this stuff, but we focus first on, can we find lesions? Can we track wires successfully? And then we've built some small data sets that look at when do physicians get into perforating or dissecting arteries, and can we predict that with small data sets? And when we see similar, anatomical structures, can we slow the wire and reduce the delivery force to more successfully? So I think there is a ton of value in this concept of intra-procedure machine learning, machine vision. But for us, it's really early, but it's probably what we're most excited about.
One of the questions on the chat talking about unlocking value is a real reality is the staffing, right? So oftentimes the robots in the OR require the same, if not more staff, which is a burden. We're all busy and we're all stretched, and the nursing staff, obviously, and the support staff are busy as well. Thoughts from you all on the approach, how we can appropriately decrease the burdens on those surrounding the patient, the surgeon, the anesthesiologist.
So there's a couple perspectives on that. Firstly, though, don't assume that there's more just because of a robot. Actually, in many cases, there's less because of a robot. And as we're going to the outpatient surgery center, which have smaller confines and actually want productivity on more operating on patients that may not be that far along in their disease progression, there's a benefit there. But your efficiency and the economic side of the data you're talking about in videotaping, and it's not just that. Don't think of the one surgery. Think of the ASC that may want to do 7 or 9 procedures a day in the one operating room or more. How can they be efficient with having 2 rooms going and someone going back and forth to different rooms? And when can that person go, depending on that technology? And can we relieve the time factor burden by doing more advanced planning prior to the case, where therefore we can reduce some of the time and increase efficiency and help profit and all that?
I like that perspective. So it's not just like for like replacing, but thinking about the entire continuum of decanting, better venue. It's an entire perspective as opposed to, just doing something different because we can. Okay.
And this conversation is different for the academic centers, the large volume community hospitals, the mid to small volume hospitals, and the ASCs. They have a different value proposition, a different efficiency they're looking for, and different capabilities.
I think it's a good point, though, in that, I mentioned the quadruple aim before, by improving clinical outcomes, but lengthening the procedure, requiring more clinicians in the OR is not necessarily satisfying the quadruple aim. So for us, it's a significant and important aspect of our research as well, which is how do we actually free up those resources? How do we make the procedure go faster? How do we make it better, faster, and require less overall resources? The answer, in part, comes back to something we've talked about already, which is empowering and enabling the surgeon, whether that be with devices or information or integration. But if you can take the need to have additional physicians in the OR and put it back into a singular person's hands at the console, you've done a great thing in decreasing resources and empowering, enabling the primary surgeon in the room.
Yeah, and I totally agree, Bob. And to build off even what Leanne was saying, look, there's when you look at the surgical suite, let's say 30 years ago, you saw a lot of people, depending on the surgical procedure, in the suite from the various nurses, multiple surgeons in place, and if you can empower the single surgeon while reducing the cognitive load at the same time, then you have something like of true value there, longer term.
Yeah, I think it goes back to the. Oh, go ahead, Doug.
I was going to say you go and I'll follow.
There you go.
All I was going to say was around thanks, Michael. That data-driven decision making. That's the bottom line. It's not only about clinical outcomes, but the more data that we can collect intraoperatively, pre and post-operative, that what happens in the clinic? How can we make clinic visits more efficient, right? As we bring on telehealth and within more My Mobility app, we're looking at that. Can you text back and forth instead of having to go in for a 45-minute visit? But as we understand, again, what's taking a long time and what's burdensome, I think it's not only going to be the outcomes that are going to get better, we're going to get the efficiencies, we're going to get the value add, having the data and driving our decisions based on what is happening.
I wonder if it's about, the question is about more or less personnel, but, rather be about efficiency. And a comment was made about the pre-planning and maybe pre-rehearsal and then implementing with some semi-automation and higher speed than a human ability. Many different factors can play a role into making us more efficient in the OR and a quicker turnover. I think that would be a big impact on value.
Yeah, and Dr. Morse, we agree with everything about efficiency, but we've thought about this. It's probably the procedure set we're doing from a bedside technician, an operating surgeon, or an operator. We actually think robotics opens up. We've seen robotics labs light up people's engagement, that they're learning new skills. They're part of how medicine's moving forward. And when you look specifically at remote robotics, I don't think any of us envision, a physician at one end with one physician at the other and another physician on backup. That's how, interventional medicine started in the heart. There was always a surgical backup to an interventional cardiologist, but eventually that surgical backup went away. We in remote robotics see the patient side physician one day less needed than the remote physician, which opens up a whole new classification for who's in that room and who's working. So we think there's some exciting opportunities for people that are in the room with robotics, and it opens up career paths and development opportunities that typically get lost in the efficiency discussion.
And it also allows, inclusion of the high volume, high experience surgeons and the less experience. So it kind of levels the field a little bit and allow to serve more patients efficiently.
Yeah, I love about this is not a talk about robotics and technology. It really is around creating value, better quality, better outcomes, more efficiency, or care extenuation for ultimately a lower cost and disease burden. Some questions, we touched upon it a little earlier around kind of the open and close aspect. There's probably several developers who would love to access the intuitive, SDK to say, hey, listen, I have a crazy idea around, sensor. Obviously, we're not going to do that because of the regulations for FDA. But just from the manufacturing and the company perspective, what is that balance between creating an ecosystem in which a rising tide raises all boats and you enable other add-ons versus you kind of have to be the masters of your own domain and doing a purely closed model, or is it both?
It depends on the procedure. That's part of the question, because some procedures won't allow that, right? So if you're putting in a very prescriptive implant and an implant has a configuration that requires a certain bony geometry, that robot is programmed to execute that bony geometry and to get the implant where the specifications and the regulatory acceptances globally have given it clearance with those indications. So it's a lot harder for doing that. Things like on a sports medicine application, let's take a hard tissue application that may be more appropriate to respond. And let's take ACL reconstruction, where now a robot wants to channel a tunnel and put a graft in exactly where that patient needs that graft. And now you're using three-dimensional data to go forward with that. Now that may be an opportunity that's more bone graft enabled. Take femoral acetabular impingement. So there are certain applications which I think more of an open platform that allow a surgeon maybe to adopt it more to their surgical technique and workflow specific for that. But again, you untangled it now from a specific implant. So there's opportunity.
That's great. Others?
I think there's some interesting opportunities on that pre and post-operative care, actually, more than anything else. If we have, robots that are being used for different applications and different surgeries, the pre and post-operative, the way the platform works, if you have someone that's going through a care pathway for a knee surgery or a different care pathway for spine or shoulder or whatever that may be, maybe there's something there. If the application, the way ours works today is, you have education, it's surgeon-centric, they set up what they want their patients to do pre and post-operatively. You could see that potentially overlapping into a more general surgery space, right? And then leveraging, an general surgery robot in the middle for the intraoperative data.
Yeah, I think this was mentioned a little bit earlier. The barriers there are significant. There are regulatory barriers. There are technical barriers. There are financial barriers to kind of having an open platform. So there's the value there, or the overall value really needs to be significant for you to kind of work and split up and address those barriers. In some cases, they do make sense, and as a company, we've done that. I also think about what part of the ecosystem are you talking about? I mean, if you're talking about impacting directly the procedure and the patient, the barriers are really significant. If you're talking about information, preoperative, postoperative follow-up data, I think they start to break down. And not only that, I think your specialization in those areas is more diverse, and the ability to leverage somebody else's talent, capability, and kind of bring them into your ecosystem, it becomes a little bit better.
That's fantastic. So we are coming up on the hour, and since there's 7 of us, our rapid question might be the final one. But I'd love each of you to kind of, I've learned a ton, and I'm not a surgeon, so this has been tremendous education and awareness. But the robot is one piece of this broader ecosystem in which all of you are really espousing to change and elevate the conversation. I'd love to kind of hear each of your perspectives. What information or misinformation do you oftentimes debunk? What is ascribed to robotic surgery that oftentimes that you find yourself constantly trying to, re-educate, re-guide, re-point? So I'd love to kind of, go through the list. Robert, from Stryker's perspective, unbelievable 40% adoption. So maybe you don't have this problem, but what has been the number one debunk issue or misinformation?
So the misinformation is the robot's taking the surgeon out of the equation, and the robot's doing the surgery. It's robotic assisted surgery for a reason. The surgeon's still deciding the target for the implants. The surgeon's still deciding what that specific patient needs. And the robot is helping as a tool of a power instrument. Think of it like a power instrument, executing that surgeon, helping execute that surgeon's plan exactly where that surgeon wants it for that patient. So it's still about the surgeon assessing kinematics and all that. So it's still about the surgeon. Just look at it in those cases like another power tool.
Is that, I have to do a follow on, is that pushback coming from the surgeons who are nervous about this brave new world? It much as like radiologists, get fearful of AI replacing them, or is it coming from the general public saying, I don't want my surgeon using a robot because I don't want the robot?
No, the adoption with the general consumer has been amazing. And if I told you as a patient, you'll get it more precise and individualized medicine, and this is the tool that enables it, we're good there. But now, if you don't have enough time for this, but you want to do demographic information, you want to talk about age profile of surgeons, you want to talk about adoption, you want to talk about people who just have different expectations. And you do have a certain population which are believe that they can do surgery better than with technology. And I think over time, though, as more people adopt it, they'll get there. It's just hard to advance that at a faster rate.
I appreciate that. Data and outcome is king. Dr. Kaouk, I wonder if you could share what is, from both a surgeon perspective, trying to convince other surgeons, trying to convince administrators to purchase your capital, or trying to convince patient? Where do you spend your time kind of debunking misinformation?
Again, I will get the discussion back to value, because the discussion should be value, not just dollar amount, because that can be sometimes misleading. The general misconception is that the robot is too expensive, and that may not make it sustainable for many procedures. Well, history proved that that's not the case for many applications that, as your guest mentioned, 40% adoption for some new surgeries in the States. So the focus really is that if there is a new technology that brings value, especially if it's value to the patient, to the surgeon, and to the healthcare, then it's a win-win, and you cannot stop it. So that's where I would focus with any discussion about the new system adoption.
That's great. Bob?
So I can actually let you move on. Those are the top two.
You can just say ditto.
I object to the term robotic. Robotic is a misnomer. It is robotic assisted. Number one. Number two is cost. And cost, people are one, if they really know their cost well, they typically are looking at just a small piece of the overall picture and kind of not looking at the overall continuum of care and the impact on the healthcare system.
Fantastic. Mike, from Ximedica's standpoint?
Well, I think it's having people understand the current patient journey, the current physician journey, the current various journeys of the various stakeholders in place, and then show them the new potential journey, right? Show them that the design of the procedure itself probably will need to change in order to really understand the whole value of it. And if you can design the procedure in combination with the overall journey and the surgical assisted robot, I think you can really convince people that the value is going to be there because you're following those steps and bringing those people along. So I think that's the greatest challenge, because it's really us as humans to really be okay with something doing it differently and moving forward, and that there is a potential way to go forward. Otherwise, we wouldn't be here, because 20 years ago, I would bet you that people would say there's regulatory challenges. It's really complex, robotic system, the data analytics, that's going to be way out there. And we're already here. So I'm very optimistic that we can actually solve these challenges just by being open to the potential of getting to that next stage.
That's fantastic. I'd love to hear from Doug, your perspective from Corinthis. I'm curious, orthopedic surgeons more challenging or cardiologists? You don't have to answer, but you can wink twice if I'm right.
You can say both. No, I think I was going to say, like Bob did, ditto. We have the same. It's funny how there are so many common threads, that it's the the cost of the robotic procedure and the fear of replacing physicians. But when Robert was talking to us, nodding along, we see robotic assisted kind of as the core value of providing this tool to the physician, and you take things off their plate, like in our case, moving wires and catheters, and they focus on case strategy, room control, complication management. And we think it actually leverages physicians for what they were trained for, which are decisions and care. So we get it all the time. Will we replace the physician? We actually use the automotive industry all the time to say that, there's a lot of players in autonomous navigation in cars that also keep drivers in the loop. They're not all getting rid of the driver. And I think it's how we think about it at Corinthis.
That's great. And Leanne, final word?
Yeah, so I think we're all on a journey to truly transform the delivery of healthcare using robotics, technology, and data. And after today, the future is truly very, very bright. I think, what I would say is that there's an underappreciation for how good the outcomes really are and how much better they can even get into the future, and that cost of acquisition and utilization isn't a limiting factor. Get on board. This is where we're headed.
I love it. So with that, I really wish to thank Robert with Stryker, Bob with Intuitive, Dr. Kaouk with Cleveland Clinic, Mike with Ximedica, Doug, Corinthis, and Leanne with Zimmer Biomet. What an absolute honor and privilege it is. Although I'm not a surgeon, I think I'm going to patent. There's Moore's law, which is the exponential rise of computation. I think there's going to be Moore's law, which is going to be the exponential rise of robotic adoption, just by your sheer enthusiasm, passion, and your focus on value and data. True world-class, investments in evidence-based as opposed to widgets. So I applaud you all. I thank you for your time. I thank those who are participating on the chat with your feedback. It makes the dialogue a lot more engaging than me pontificating and asking questions. Please join us on December 1st. Shifting gears out of robotic assisted surgery, and we're going to be talking about small but mighty startups giving birth out of the COVID. So we're going to hear about startups who have been, trying to tackle this pandemic. I was surprised we didn't bring up COVID once during this, so that clearly tells you guys are tackling something that is truly novel and needed. So with that, I thank you very much, and hopefully we'll see you on the 1st of December. Stay well.
Thank you.
Right. Thank you.
Thank you.
Bye. Thank you.